Able to hear me loud and clear, give me a thumbs up so that I get to know I'm live. I had to make some changes in the settings. I am just coming from an app-based class, so I need a little confirmation before I start whether I'm live and streaming. Once you give me the confirmation, we will get going. Okay, it appears that I'm live, and welcome everyone. So in this session, we will be spending around 30 to 40 minutes understanding diarrhea. There are two aspects to learn here. One, there will be MCQs based on diarrhea. The MCQs based on diarrhea are widely spaced, means you will get MCQs from microbiology, you will get MCQs from biochemistry, you will get MCQs from medicine. Okay. Now, trying to address everything will be too vast for us. So, let me keep it concise and make it more relevant for the clinical discussions. When you go to the bedside case discussion, one of the common complaints of patients is diarrhea. And examiners tend to ask some basic questions. When do you call it as acute diarrhea? When do you call it as chronic diarrhea? When do you call it as subacute diarrhea? What are the common causes for acute diarrhea? What are the common causes for chronic or subacute diarrheas? Those are common questions. And how to evaluate a patient presenting with diarrhea. These are the basic things that we will address today. And as we proceed further, right, in the subsequent sessions, definitely we will also go through more microbiology based questions and more pharmacology as well as the biochemistry based questions. Okay. So let me begin first by addressing what is diarrhea. It's a very vague term, right? When you say diarrhea, patients will come and say that I have got loose stools. Okay. Now I have a patient A who is passing 3 or 4 times stools per day, small quantities, but it is according to him liquid in consistency. That is not what he normally used to pass like. And I have patient B who is passing stool 2 times a day, large bulk. He says that previous days I was not passing so much stool, I am passing large bulk of stool now and I feel I have diarrhea, right? Both patients are feeling diarrhea. Both patients say that they have got diarrhea. But as a doctor, I need to objectively understand whether I should call it as diarrhea or not. Let me increase the volume a bit, guys. Okay, am I audible now? Shreya Agarwal, over next 6 to 7 months, we will be covering most of the major topics that you need for your final MBBS. Okay, so I need to understand, because patient complaints are going to be subjective, just like I feel tired. It's a very subjective complaint, right? I can lift a 20 kg dumbbell, but I still feel tired, right? There is another person who is not able to move the limb at all. He also feels tired, subjective complaints, right? So in case of weakness of muscles, we objectively assess by looking at the power of the muscles, right? We have 5 grades of power. So similarly, most of the subjective complaints need to look at with an objective mindset. Now this is a definition that I get in the Harrison's. He says diarrhea is defined as passage of abnormally liquid or unformed stools at an increased frequency. But it is a very subjective definition. What do you mean by abnormally liquid? Right? Have we checked the consistency, or do we have a measure to check the consistency? No. What do you mean by unformed stools? Right? Aaj sham ko maine, like I had some sweet corn. Tomorrow I might see the sweet corn kernels in the stool. That doesn't mean that I have developed diarrhea, right? Similarly, he says increased frequency. Now, have we set a normal definition for frequency? Like passing 2 times a day is normal, more than 2 times is abnormal, or passing only once a day is normal, more than once a day is abnormal? No, right? So then how do I objectively define diarrhea? Okay. So please remember, there is an objective definition also. The conceptual definition is when patients start passing abnormally liquid stools, unformed stools at an increased frequency, we can call it as diarrhea. But the objective definition is looking at the stool volume, right? Stool volume or stool weight more than 200 grams per day for patients on Western diet. Right now, when I bring this weight into picture, it doesn't matter about the frequency or the quantity, right? Like it has to be more than 200 grams per day, whether you pass that in 1 go or whether you pass that in 4-5 go, it all will be counted as diarrhea, okay? But please remember here specifically the book mentions Western diet. Now you should tell me what should be the cutoff to call it as diarrhea for patients with Indian diet. Do we have more fiber in our diet or less fiber in our diet? In Indian diet, the fiber is more or less? Obviously, like Western diet is full of processed food, right? मैदा खाते हैं, जो कुछ भी खाते हैं बस मैदा ही है, right? पास्ता से लेके कुछ भी, rarely ever they use wheat and whole grains. Mostly it is maida, right? All pastries, patisseries, everything is maida. Pizza का base भी मैदा, right? wrap भी मैदा. And because of that, their dietary consumption of fiber is much less than the average Indian diet. जब तक आप इंडिया में घर का खाना खाते हो, you have a good supply of fibers because we have traditionally included whole grains in our diet and good load of vegetables and leaves, right? So that is why we need to convert this definition adaptable to Indian diet. So for Indian diet, the stool quantity more than 400 grams per day. If the patient is on Indian diet, then we will call it as patient having diarrhea. Otherwise, right, most of us would agree that we generally pass more than 200 grams of stool per day, and then that means that whole Indian population is having diarrhea persistently, right? From birth to end, they will have diarrhea, right? So in Harrison, this is not mentioned. They have not mentioned the definition for diarrhea on Indian diet, but they have mentioned for the Western diet, right? So one definition he has given is passage of abnormally liquid or unformed stools at an increased frequency, and then he mentions that if the stool weight is more than 200 gram, for a patient on typical Western diet, it will be considered as diarrhea. But add a point to that, if it is Indian diet, it is 400 grams. Clear? Okay. Now that is the first thing we have to address. Now we have eliminated the subjectivity. Whether you pass that 400 grams in one go or in 10 go, it will all be counted as diarrhea. Okay. But that brings one more important question that examiners ask you during the bedside discussion. Do you know what is pseudo-diarrhea? Okay. So pseudo-diarrhea refers to the condition where there is increased stool frequency. Increased stool frequency. Patient may complain that I go to the bathroom 10 times a day, 15 times a day, right? But stool weight is less than 200 grams per day. Obviously, we are referring to Western diet. And if I have to extrapolate it to Indian diet, a patient on Indian diet, if he complains of increased stool frequency, but his stool quantity per day is less than 400 grams, it means he is having pseudo-diarrhea. It means it is not true diarrhea, right? Okay. Now, what can cause pseudo-diarrhea? That is the next question that examiners will shoot at us. What can cause pseudo-diarrhea? Pseudo-diarrhea can happen in two conditions. One is irritable bowel syndrome. Many of your friends, batchmates may also be having this irritable bowel syndrome, right? It is a very common functional bowel disorder where there is no major pathology with your gut, but patients have a tendency to pass stools frequently. And you know that there are different variants of irritable bowel syndrome. There is a variant called as diarrheal variant, constipational variant, mixed variant, and unclassifiable variant. All that we will discuss later. For now, remember that many patients with irritable bowel syndrome, they have increased stool frequency, but their total per day stool quantity does not exceed more than 200 grams per day. So we will call it as pseudo-diarrhea, right? Another condition is proctitis. What is proctitis? Inflammation of the rectum, right? We call it as proctitis. Can anybody give me an example or a condition where we get the proctitis? Proctitis. One disorder which causes proctitis. One inflammatory bowel disease which predominantly affects the rectum. So you might have heard about Crohn's disease and ulcerative colitis, right? So can anybody tell me which one affects the rectum more? Which one affects the rectum more? Is it Crohn's disease or the ulcerative colitis? Okay, so please remember these two terms are there, right? Crohn's disease and ulcerative colitis. One of them we call it as disease, Crohn's disease. The other one we call it as colitis. Why is it so? Because Crohn's disease affects anywhere from mouth to anus. On the other hand, ulcerative colitis only affects the colon. It does not affect the small intestine or other part of the GIT, and the involvement usually starts in the rectum, So ulcerative colitis begins with the rectum and then ascends to involve the rest of the colon. Crohn's disease is least likely to affect the rectum. Firoz Ali Khan, it can help you to score the clinically oriented MCQs, but the course is primarily designed for those who are starting to study medicine early, not towards their internship period or towards the last month of their final MBBS preparation, because in such cases you will be spending a lot of time, right? Ulcerative colitis predominantly affects the rectum. So patients with ulcerative colitis can develop proctitis, and such patients can also have pseudo diarrhea. In fact, if you go back to the pathology and study about Crohn's disease and ulcerative colitis, you will learn one point. Crohn's disease, the most common presenting complaint is abdominal pain. And the most common presenting complaint of patients with ulcerative colitis is diarrhea with blood or bloody diarrhea. Okay. And because many of them in the milder stages will have increased frequency but not the quantity exceeding 200 grams per day, we will be labeling them as having pseudo diarrhea. Okay. So there are two conditions where we can have no diarrhea but increased frequency. One of them, as I have already told you, is pseudo diarrhea. Harrison does mention about it, frequent passage of small volume stools, but the total stool volume less than 200 grams per day. And the second condition is when you have fecal incontinence, means your anal sphincter is not able to close properly, and because of that patient will have continuous or frequent leaking of the stool. Obviously normal stool is formed, but because the sphincter is not closing, they are not passing it in one go or two goes that we normally do. It is leaking frequently. So in those patients also stool frequency will be increased, but because there is no pathology, normal quantity of stool will only be produced, so they will not exceed more than 200 grams. So this can be an MCQ. In what conditions you can have increased stool frequency but stool quantity does not exceed 200 grams per day? Pseudo diarrhea, and the second one is fecal or anorectal incontinence. Clear? Okay. Now once we have objectively understood what is diarrhea, the next question is, how do you classify a patient presenting with diarrhea as having acute diarrhea, subacute diarrhea or chronic diarrhea? For every symptom that we study, we should know when do we call it as acute, when do we call it as chronic, when do you call it as subacute, just like how we did for the cough, right, or dyspnea. Here also for diarrhea also we will have a time bound definition. So we will call it as acute. We will call it as acute diarrhea if the duration of the diarrhea is less than 2 weeks, and we will call it as chronic diarrhea if the duration of diarrhea is more than 4 weeks. If it is more than 4 weeks, and if it is in between, there are two terminologies that we can use to describe it. If it is between 2 to 4 weeks, either you can call it as persistent diarrhea or you can call it as subacute diarrhea. Persistent is the word that Harrison generally uses whenever he wants to talk about the entity. In common Indian discussions or during bedside discussions, we use the term subacute. Persistent or subacute diarrhea is the one which lasts for 2 to 4 weeks. Okay. Now the question is, which one is more dangerous? Acute diarrhea or chronic diarrhea, or both? So Tapa, we will be taking up the other systems. So please remember, acute diarrheas, the main problem in most cases will be dehydration. If hydration is taken care, it is not a major entity, because more than 90% cases of acute diarrhea are because of infections, and most of the infections are self-limiting. On the other hand, chronic diarrheas, almost all of them have some underlying serious diagnosis underneath. Means it could be irritable bowel syndrome, inflammatory bowel disease, Crohn's disease or ulcerative colitis. It could be the tuberculosis of the intestine. It could be malabsorption syndromes, celiac sprue, tropical sprue. You will have one major underlying diagnosis whenever you have chronic diarrhea, right? So acute diarrhea is what we will address first. So please remember, when you have a patient presenting with diarrhea of less than 2 weeks, 90% of these cases are infectious, and 10% of these cases are going to be non-infectious. Can anybody tell me few causes for non-infectious diarrhea? Infection we will discuss with some reasonable detail, but some causes for non-infectious diarrhea. You don't have any acute gastroenteritis or infection of your intestines, but you still have diarrhea. What can cause that? Pregnancy, well, okay. Agreed, okay. Other than pregnancy? Fever per se won't cause diarrhea, but many infectious diarrheas, obviously when there is an infection, fever will also come, right? Many infections will cause diarrhea as well as fever. Right, drugs are the most common cause for non-infectious diarrhea. Most common cause for non-infectious diarrhea are drugs. So can anybody name some drugs which are known to cause diarrhea? Drugs known to cause diarrhea. Okay, some of you may be in second year and third year and you may be very new from pharmacology and you should be able to tell. Drugs, a very good answer, but what are the common drugs which are known to cause diarrhea? In fact, just recently concluded INI-CET was having an MCQ on the side effect of one of the drug, which was diarrhea. They were asking which of the following anti-diabetic is known to cause diarrhea. The fresh question, right, metformin. Debraj Sarkar, absolutely right. So the question is, the answer for that question was metformin. Metformin is known to cause diarrhea. Okay, but first thing that should come to our mind is antibiotics. A lot of antibiotics increase the gastric motility and can cause diarrhea. Many of us have experienced it also, right? Antibiotics. Then second, metformin. Okay. Then many antacids, especially those contain magnesium, right? Magnesium, those contain magnesium salts like magnesium silicate, magnesium hydroxide. Those antacids can also cause diarrhea. Okay, so the list can go on, and as you all know that lactulose is anyway given with an intention to induce diarrhea in patients with hepatic encephalopathy. Yeah, so it is as you know, it is an osmotic laxative. So it is known to cause diarrhea as such. We give it with the intention that we should induce diarrhea. But you open pharmacology book and you open any class of drugs, right? Every class of drug will have at least one drug which is known to cause diarrhea. Okay. Then coming to infectious, what is expected from you is, first thing examiner will ask you is, who are those patients who are at risk of developing infectious diarrhea? That is one. Second, for all those risk categories, he will ask, what is the most common organism? For example, people who visit India from Western world like UK, US people, when they come to India, within first 2-3 weeks, they develop diarrhea, right? What we call this as? Yes, immunocompromised are definitely at risk. Travelers to some developing countries from the developed world are at risk of developing acute diarrhea. What we call it as? We call it as travelers diarrhea, right? So one of the questions that they will ask you is, what are the individuals who are at risk of developing acute diarrhea? So one of them is travelers. And you know from microbiology, frequently they ask a question, travelers diarrhea is caused by, right? Then consumption of certain food items. If you are fond of consuming certain food items, those food items may be contaminated and increase the risk of developing certain infections. For example, ice creams, right? Ice creams can be contaminated with salmonella. Salmonella finds comfort in growing in ice creams. So if you develop loose stools after eating ice creams, it may be salmonellosis, right? Similarly, E. coli, especially the enterotoxigenic E. coli or ETEC, is a very common cause for diarrhea among the travelers to India or Asian countries from the Western world, right? Then third, as you mentioned, immunocompromised state. Patients who are immunocompromised, obviously they will not be able to defend their gut against the invading bacteria. For us, right, हम सड़क पे जहाँ पे चाहे जो चाहे खाते हैं, most of us will tolerate it well because our immune system can handle it. But if you're immunocompromised, well, you may not be able to handle the simple microorganisms and you will end up developing diarrhea. These are the important risk categories. So let me tell you what Harrison talks about the risk categorization. So Harrison also classifies the diarrhea into acute, less than 2 weeks, persistent 2 to 4 weeks, and chronic more than 4 weeks. Okay. And in acute diarrhea, the risk classes travelers, right? And he mentions that nearly 40% of the tourists to endemic regions, which includes Asia, end up developing loose stools. We call it as travelers diarrhea, and the most common organism responsible for it is the E. coli, right? That is indeed an MCQ. The most common cause for diarrhea among the travelers is going to be E. coli, and you know that there are different types of E. coli. To be more precise, it is the enterotoxigenic E. coli or E-tech, which is the most common organism. The second risk factors is those who consume certain foods, right? Those foods increase the risk of developing diarrhea. And then among them, there are few points to remember. Okay. One I want you to remember is if you use Chinese fried rice, that is an MCQ, or food that is reheated and after that you develop diarrhea, you should start thinking about Bacillus cereus infection. Bacillus cereus infection. This is again an MCQ. Chinese fried rice induced diarrhea. That is Bacillus cereus. Okay. Similarly, if patient develops diarrhea after consuming frozen desserts, think of salmonellosis, right? Think of salmonellosis. Okay. If after consuming mayonnaise, patient develops diarrhea, think of Staphylococcus aureus. Okay. Ice creams, think of salmonellosis. Mayonnaise, think of Staphylococcus aureus. Chinese fried rice, think of Bacillus cereus. These are some pointers which might help you to reach the underlying cause. So if after Chinese fried rice you get diarrhea, think of organism called as Bacillus cereus. Okay. If you develop diarrhea after consuming ice creams, think of Salmonella. And after consumption of some contaminated mayonnaise, it could be Staph aureus. Could be Staph aureus. Okay. See, guys, our Indian genetics is really robust, and it will definitely, like, over the years, we have started living well adjusted with many microorganisms. And only in the recent last 2 or 3 decades, with the rise in our economy, our diet is also getting messed up and we are getting more attached to the Western diet, and that is where all these infective diarrheas are becoming more common. Otherwise, in the past, it used to be only like cholera, which could really harm us. Otherwise, most of us used to develop loose stools in the morning. By evening, we're all right. But yeah, with the passage of time, we are lacking the opportunity to train our immune system. But I'm sure our age will be able to handle it. So you don't need to worry about getting malnourished. As of now, I think as medical students, we should be more worried about being obese by the time we finish our MBBS, because we are stressed. We sleep late, study a lot of hours, no time or scope for physical activity. So most of us become obese rather than lose weight. Okay. Then third is immunocompromised state. Immunocompromised state also increased risk of certain opportunistic infections, apart from increased risk of common organisms like E. coli, rotavirus, salmonellosis, Bacillus cereus infection, right, Campylobacter jejuni infection. Apart from these, certain rare organisms, their risk is also increased. Okay, so immunodeficient persons is another risk factor. And particularly, I want you to remember that these patients are at increased risk of getting infected with Cryptosporidium, Isospora belli, Microsporidia. These are again common infections that we see in HIV individuals, right? What are those? Cryptosporidium, Isospora belli, and Microsporidia. Okay. Apart from these 3 risk factors, there are 2 more risk factors that increase the risk of someone developing acute diarrhea. That includes patients who are getting admitted in daycare facilities. Means like those patients who need to go for dialysis. They go in the morning and by afternoon they finish the dialysis and come home. Or those patients who go to the hospital to receive chemotherapy. They morning get hospitalized, receive the chemotherapy, evening they are getting discharged. We call these as daycare facilities, right? They are getting exposed to hospital environment and that can infect them, and thus they have a higher risk. And then individuals who are institutionalized. Now, what is the meaning of institutionalized? It refers to staying in nursing homes. Now, the term nursing home in India means different, and the nursing home in the Western world means different. So, small clinics or small hospitals with few beds, in India we call them as nursing home, right? But they are also small hospitals. The term nursing home refers to the institutes where the patients who are elderly or those who need nursing care are housed. Whether they need medical care or not is different. Whether they need or not, they are still housed in those institutes because they need nursing care or attendance. They are not able to care for themselves. Most of them are old age homes, right. So, patients living in those places where the nursing care is required, they are also at increased risk of developing acute diarrhea. So, those are the two more things that we need to add to the risk. Daycare facility attendees and nursing home residents. Nursing home residents. These are the patients who are at increased risk. Okay. Now, so far what we know what is diarrhea, right? Diarrhea, the objective definition is when stool volume is more than 200 gram per day on Western diet or more than 400 gram per day on Indian diet. We also know what is pseudo diarrhea, when stool frequency is increased but total stool count doesn't cross more than 200 grams per day on a typical Western diet or more than 400 grams per day on a typical Indian diet. We will call it as pseudo diarrhea. Presence of pseudo diarrhea doesn't mean that there is nothing wrong with the patient. It simply means that I can't call it as diarrhea. Patient has a disease, patient has IBS or proctitis, but I can't call it as diarrhea. Less than 2 weeks we call it as acute diarrhea, 2 to 4 weeks persistent or subacute, and more than 4 weeks chronic. Most of the persistent or subacute diarrheas are nothing but improperly recovered acute diarrheas. Chronic diarrheas is an entirely different entity. Right. Later we will discuss about the chronic diarrhea. Right now we are concentrating on acute diarrhea, and we have learned that 90% of acute diarrheas are infectious, 10% are non-infectious, and when it comes to non-infectious, drugs are the leading cause. Okay. And when it comes to infectious diarrhea, there are few sets of patients who are at increased risk. That includes travelers to endemic countries from non-endemic zones, consumption or being fond of certain foods because those food items can be, they have a tendency to get contaminated with a peculiar organism. If your immunity is low, if you are attending daycare facilities for some regular treatment, or if you are staying in a old age home or a nursing home for nursing care, you are at increased risk of developing diarrhea. Okay. Now, though 90% of acute diarrheas are infectious, you go to any good doctor, I am saying good, not like a random doctor, you go to a good doctor and say, sir, from 2 days I am having diarrhea. All he will tell you is drink more water, take ORS, and hopefully you should be all right. He will not prescribe you antibiotics, right? Why? Because out of those 90% infectious causes, right, 90% of those 90% cases are self-limited. They are not going to create any life-threatening situations. So, over 2 to 3 days time, the loose stools will settle on their own without antibiotics because your immune system is quite robust and capable of handling it. If I prescribe antibiotics, it is unnecessary. It is antibiotic abuse, and it increases the risk of you developing more resistant organisms later part of the time, right. So, then obviously a question comes, which acute diarrhea patients require antibiotics and further evaluation, and this is what our examiners will routinely ask us, right. Which patients require antibiotics and which patients require further evaluation, because 80% patients who come to my OPD saying that from 3 days, 4 days, 5 days I am having diarrhea, mostly I turn them off by just prescribing them ORS and good hydration, right. So, that is a question that we need to address, which patients of acute diarrhea require further evaluation. Beyond the supportive care, what is the supportive care? Hydration and oral rehydration salt. That is all we do for most patients, right. So, those patients who have profuse diarrhea and they have presented with dehydration, they require further evaluation and they will definitely or probably require antibiotics. Okay. Those patients who presented with gross bloody stools, when patients present with bloody stools, we call it as dysentery. We call it as dysentery. So, the diarrhea, dysentery, what is the difference? In dysentery, you have blood in the stool. In diarrhea, you generally don't have blood in the stool. But you can say that dysentery is a subtype of diarrhea where apart from having increased stool quantity, you have blood also in the stool. So, we call it as dysentery. And whenever you have blood in the stool, in an acute setting, I am not talking about chronic disorders, we will discuss that later. In an acute setting, mostly it indicates that you got infected with an invasive organism like enteroinvasive E. coli, Shigella, right, or you might have developed salmonellosis with ulcers in your gut, and in that case we need antibiotics. That is why it calls for further evaluation. If patients present with fever, that too mild fever is part and yes, Yersinia also. Mild fever is part and parcel of loose stools. Like most of us, when we eat something outside and we develop diarrhea, for one day we will have some mild fever. Again, that does not call for use of antibiotics. The fever indicates that your immune system is fighting against the bacteria. But when fever is more than 101 degree Fahrenheit, that again points towards possibly an invasive microorganism like enteroinvasive E. coli, right? So in such cases, we need to probably give antibiotics, and that is why it calls for further evaluation. Okay. Then majority of the patients who develop loose stools start improving within 1 or 2 days. Like I started loose stools today, by tomorrow mostly I will be better. But when loose stools last for more than 48 hours without showing any signs of improvement, see, if it is improving, well and good, I don't need to do any further investigation, I don't need to give you antibiotics. But 48 hours have passed since the onset and it is not showing any signs of improvement. Yesterday also patient had 20 frequency, today also he has 20 frequency, tomorrow also the frequency is 20, no signs of improvement. Such cases would require further evaluation. Okay. Similarly, if patient had recent exposure to antibiotics, that would require further evaluation. Can anybody tell me why this is a concern? Like patient had taken 2 weeks of antibiotics in the oral form and now he has presented with loose stools. What should be my concern? I know antibiotics are known to induce diarrhea, but still I will have one concern or fear in my mind. I will have one fear in my mind. What is that? Right? There is a possibility of Clostridium difficile colitis, which is also called as some of you may be knowing, we also call it as membranous colitis, also known as membranous colitis, which the frequency of it is increasing robustly in the recent times because antibiotics are being used left, right and center, whether it is indicated or not. Whenever you go to a hospital with some inflammation, some fever, the tendency among doctors to prescribe antibiotics is so high that every second prescription carries an antibiotic. And some of the individuals, when they take antibiotics, they end up losing the normal gut flora. See, we have some normal bacteria in our intestine which are commensals, we have a symbiotic relationship with them, but antibiotics will kill them, making way for more pathological bacteria, and one such bacteria is Clostridium difficile, which causes membranous colitis. Right, Nilanjan Roy. Clindamycin, and now we have also moved away from clindamycin and we have better drugs to use for membranous colitis. Okay. Then third, if the patient is part of an outbreak happening in the community, obviously we should start thinking about the possibility of cholera. Right now in Bangalore, if you come to my clinic and say that, sir, I have loose stools from last 2 to 3 days, right now because Bangalore has reported few cases of cholera, I would be vigilant and I will definitely investigate you instead of just asking you to take some oral rehydration salt and some hydration methods, because possibility of cholera is quite high because outbreaks are being reported from my place. Similarly, if I am in some other part of the country right now where no outbreaks happening, then I won't give a concern about the patient's diarrhea. If he says 2 days of diarrhea, I would say take care of your hydration, you should be all right, right? So possibility of Vibrio cholera should be concerned whenever patient is part of an outbreak. Okay. Then immunocompromised patients, obviously because in them even a simple E. coli, enterotoxigenic E. coli can be catastrophic. That's why we need to investigate and treat with appropriate antibiotics. And similarly, elderly individuals, they may not be able to deal with the infections well. They may get dehydrated early. So that needs further investigation and antibiotic treatment. Clear? So this is the point we need to know, in which patients we need to further evaluate if they have diarrhea. So far we have understood what Harrison talks about diarrhea. He says the definition of diarrhea, he classifies them into acute, persistent and chronic. Then he also gives the definition of pseudo diarrhea. And then he categorizes the infectious diarrhea as 5 risk groups: travelers, consumers of certain food, immunocompromised individuals, daycare attendees and institutionalized persons. Okay. Then after that, he gives us an approach to diarrhea. Okay. So what he says, whenever we have a patient with diarrhea, we have to do a thorough history and physical examination. Medicor 37, absolutely right. So fidaxomicin is now the drug of choice for the treatment of membranous colitis. So all those who are in second year or third year, now like no need to get super saturated with information. We will primarily concentrate on learning about diarrhea, and as time progresses, right, you start studying more pharmacology and more core medical topics, you will start adding information to your base. So we will concentrate more on building the base. Okay. So whenever you have a patient with acute diarrhea, that means diarrhea of less than 2 weeks duration, we have to make good attempts at taking good history and physical examination, mainly to understand whether it is likely infectious or whether it is non-infectious. Right? From the history, I get to know that patient had taken certain drugs which are known to cause diarrhea. Then obviously I would blame the drug for the diarrhea rather than think of infection. For example, you might have heard of a drug called as erythromycin, which is known to cause diarrhea. Erythromycin is an antibiotic, but it has a specific mechanism for causing diarrhea. What is that? It stimulates a receptor called as motilin. You might have studied about it in pharmacology, right? And that increases the intestinal motility. So because of that, we can have increased stool frequency. Patients can also have abdominal cramps, right? So if you say that the patient was started on erythromycin 3 days back, 2 days back, and now he has diarrhea, I know it is erythromycin induced, right? So that is why history becomes important. So on history, if you find out some clues to say that this is not related to infection, then we have to just treat the underlying issue, right? Erythromycin is inducing it, I have to stop it, that's it. But if I don't find anything such pointers towards non-infectious causes, then I would take it as likely infectious. And as I've already told you, most cases are going to be mild and self-limiting. So in such cases, we will just observe them. We will give them some fluid and electrolyte replacement, which is nothing but asking them to drink fluid rich in electrolytes and maybe ORS, and we will observe how things progress. If it resolves, well and good. Most patients resolve. Okay. Same applies to patients with moderate diarrhea. Okay. But those who are severe and incapacitated, means those who are severely dehydrated, confined to bed, right? In them, we need probably more institutionalized assessment. I might need to hospitalize and assess. Okay. Now, what do I assess? I will check the fever more than 101 degree. I told you already that it calls for further evaluation, right? If there is bloody stool, it calls for further evaluation. In the feces, if there is increased WBC count or pus in stool, it indicates further evaluation is required. If patient is immunocompromised, it indicates that further evaluation is required, or elderly means age more than 70 years, it requires further evaluation. So all these points we have already elaborated. How we evaluate, that's the question, right? How we evaluate? We will start with the stool microscopy. In the stool microscopy, you may be able to identify certain organisms. For example, if you have Vibrio cholera, right, the stool hanging drop may be able to identify it, right? Some parasites which are known to cause diarrhea, you may be able to identify it from their eggs in the or cysts in the stool, right? If you don't find anything there, you probably need to do more detailed evaluation, which will be stool culture. Stool culture may be able to grow the organisms. If you identify the organisms, then you will use the antibiotic appropriately based on the organism. For example, if I identify that patient has got Clostridium difficile infection, then the antibiotics of choice currently is fidaxomicin. So we will be using fidaxomicin. What if I fail to identify an organism? Like stool microscopy and culture does not yield a result. In that case, but these patients definitely need antibiotics because they are having fever, bloody stools, or they are elderly or immunocompromised, right? So in that case, what should I do? I should treat them with an empirical antibiotic. And one of the questions that we will be asked is, what should be my empirical antibiotic of choice? Let me say that I got a 70-year-old person who has come to me with loose stools. Now, being elderly, he is at risk of catastrophic outcome, and that warrants further evaluation. So I will obviously do the stool microscopy and stool culture, and I fail to find an organism there. Now I need to give an empirical antibiotic. What should be my choice? If I find an organism, yes, there are drug of choice for all these organisms. We will make a right choice according to that. But if I don't find an organism, what should be my drug of choice? So let me take you through what Harrison says about the approach to acute diarrhea. So he has already mentioned the indications for evaluation, which I have already discussed with you. Then when he goes on to talk about the drugs, he mentions that for most patients, the good choice will be using a quinolone. The word empirical refers to like shooting in the blind. If you know who is your enemy, you will target and shoot. If you don't know who is your enemy, you shoot in the blind, right? You just randomly fire here and there, hoping that it will hit your enemy. So empirical treatment basically refers to when you don't know which organism, but you still need to give antibiotics without knowing the organism. We call it as empirical treatment, right? So Harrison mentions that quinolone is the drug of choice for empirical treatment of acute diarrhea. So it could be ciprofloxacin or ofloxacin, and that is why whenever you go to doctors and say that you got loose stools, most of them prescribe you ciproflox or oflox, right? Then if you are suspecting giardiasis, infection caused by Giardia lamblia, which is again common in India, India is endemic for giardiasis. In such cases, we can use metronidazole. Another thing India is common, like India is endemic to, is amoebiasis. Amoebiasis can present as acute or persistent diarrhea. So if you have to cover amoebiasis, obviously again the drug of choice is metronidazole. So that is why whenever you go to doctors and you say I have loose stools, they end up prescribing Oflox TZ or Ciplox TZ, Ciplox OZ. They are nothing but combination of a quinolone, ciprofloxacin or ofloxacin, plus one of the nidazoles, metronidazole or ornidazole. That's a commonly prescribed combination. This combination is not always required until and unless you are suspecting giardiasis or amoebiasis. We don't need to prescribe the metronidazole. Imidazoles are not required because most commonly they are caused by other common organisms like E. coli, Shigella, Salmonella, which can be handled with a quinolone. So quinolone should be the drug of choice for empirical treatment. Okay. So this is our approach to acute diarrhea. When a patient presents with diarrhea of less than 2 weeks, take a good history and do a physical examination. See if you can identify an attributable cause like drugs or something. If it is there, just address the underlying cause. If not, then it is mostly infectious. As long as it is mild, we will only give them hydration and supportive care. No need for any further evaluation. Moderate to severe, apart from the supportive care, we might require further evaluation, particularly when patient is having fever of 101, bloody stools, pus in the stool, or immunocompromised or elderly. And in such individuals, right, we will probably start with the stool microscopy. If it identifies the organism or if culture identifies the organism, we will institute the appropriate drug of choice as the antibiotic. If nothing is found, empirical treatment, as I have already told you, will be with a quinolone. Quinolone will be the drug of choice for empirical treatment. But if giardiasis or amoebiasis is suspected, in such cases, we have to consider adding metronidazole. And please remember, metronidazole is one of the well-known drug to induce Clostridium difficile loose stools. So now if I get a patient with loose stools and I prescribe him Oflox OZ without the need, like a mild case which would have likely resolved on its own, and I end up prescribing ofloxacin plus metronidazole, this metronidazole might increase his risk of developing Clostridium difficile infection or the membranous colitis. So 1 week, 2 weeks down the line, he'll come back with again re-onset of diarrhea. This time, because it is an antibiotic induced diarrhea, I have to go for further evaluation, and from the stool I will do a test called as stool CD toxin, which might turn out positive. In that case, my diagnosis will become Clostridium difficile colitis or membranous colitis, which is a bit difficult to treat condition. Right now we have a good drug called fidaxomicin. Most patients respond well, but there is a high risk of recurrence, and if recurrence happens, then it is a very difficult situation for us to treat. And we have tried various antibiotic regimens and methods, and one of the recent methods is fecal microbiota transplantation. What is FMT or fecal microbiota transplantation? What we do is we take the normal individual's feces, stool, culture it, and the cultured organism from normal stools of normal individuals, we will put a Ryle's tube and administer it to the patient, right? So literally it's like administering the shit to the patient. But why the patient is requiring shit? Because some shitty doctor ended up prescribing antibiotics when it was not required, right? So that is why having a very logical understanding of antibiotics and the relationship of infections and the need for antibiotics is very crucial for all of us to become good doctors, right? Okay, so this is going to be our approach to acute diarrhea. Next up, we will concentrate on the chronic diarrhea. Most cases of persistent diarrheas are improperly healed or improperly recovered acute diarrheas. But chronic diarrheas is a separate entity, right? Diarrhea which is lasting for more than 4 weeks. Majority of the cases will have an underlying major cause, right? So first we have to understand is if a patient presents with diarrhea of more than 4 weeks, what all can be the reason, right? To call it as chronic diarrhea means diarrhea of more than 4 weeks. The causes can be secretory. Now when I say secretory causes, that means there is increased secretion of fluid or water in this patient's gut. See, normally what happens when we eat food, it already contains a good amount of fluids, right? Our rasam, sambar, curries, even whatever, right? Like dry powder तो खाते नहीं है. Whatever we eat has some amount of moisture or some amount of water. उसके बाद में पानी पीते हैं. At regular intervals हम पीते रहते हैं पानी. So we are adding lot of fluids to our gut. On an average, the gut receives around 9 liters of fluid per day. हम 2-3 liters का fluid food and water के रूप में लेते हैं, but there will be active secretion of gastric juices and all, right? So gut receives around 9 liters of fluid. Your small intestine receives around 9 liters of fluid. But as the food bolus along with the fluid passes through the intestine, we will be able to reabsorb most of the water. So we will only hand over 1 liter of liquid content to the colon. इंटेस्टाइन में शुरू हुआ था 9 लीटर पर डे, लेकिन कोलॉन को मिलता है 1 लीटर पर डे, मीन्स 8 लीटर इज गेटिंग रीअब्सॉर्ब्ड, राइट? 8 liter is getting reabsorbed. But there can be pathologies where instead of reabsorbing the fluid from the intestinal lumen, your intestinal mucosa can end up secreting the fluid, unnecessarily end up secreting the fluid. Such cases we call it as secretory diarrhea. Okay. Then there can be another category which is called as osmotic diarrhea. What does it mean? If you have some osmotically active substances in your intestinal lumen, please remember, like if this is my intestinal lumen, right? This is the intestinal wall. If there are osmotically active substances in the lumen, let me say glucose. As we know, glucose is an osmotically active substance. I'm just giving you an example. Now, whenever glucose moves, right, the osmolality of the fluid in the intestinal lumen is higher than the osmolality of the mucosal cells. And fluid, as you know from your chemistry knowledge, moves from lower osmolality region to the higher osmolality region. So if I have osmotically active substances, they will bring in water from the intestinal cells. So they are literally dehydrating the cells and getting the water to lumen. So now I will have lot of water in the lumen, which I will lose in stool. This is what happens when we have diabetes. If you have diabetes, you have polyuria. Why? Because you are excreting glucose in the urine, but glucose being osmotically active, it is not going alone, it is also taking water along with that. That's why we have polyuria when we have diabetes. So similarly, if intestine has osmotically active substances, they will not go alone, but along with that they will drag water. That is how the stool volume increases and we develop diarrhea. Just to give you an example, if you have lactose intolerance, right, just like glucose, lactose is also an active, osmotically active substance. So if you have lactose intolerance, you will not be able to absorb lactose. So when lactose is excreted in stool, along with that water will also go. So many people have lactose intolerance, right? After drinking milk, they develop diarrhea. That's because of the osmotic nature of the lactose. Right, laxatives, many laxatives are osmotic. There's a category of laxatives called as osmotic laxatives. Okay. Then third, we have inflammatory disorders where the gut is getting inflamed, and because of that, whenever there is inflammation, there will be formation of pus and exudative fluid. So we are leaking that exudative fluid into the intestinal lumen and we are losing. Example is your inflammatory bowel disease. Okay. Then you can have increased intestinal motility because of some pathology. A classical example is irritable bowel syndrome. In these patients, increased intestinal motility means that whatever that comes to the intestine, instead of spending some time there for reabsorption, it is quickly passing down the drain, and because of that you are losing large quantity of stool as well as more unformed stool. So dysmotility can also cause. And then the last category, which is extremely important for us to understand, is steatorial chronic diarrhea. Steatorrhea refers to increased excretion of fat, right? Fatty stools. Because when we eat food, at least these days, we have heavy fat content in our diet. All of that will be digested and absorbed. And then after that, our blood cholesterol and triglyceride levels will increase. That is the second story. But whatever fat we stuff into our stool will be happily and effectively absorbed because we break them down with the help of the intestinal enzymes and the pancreatic enzymes, which are nothing but lipases. But if I fail to digest the fat well, or I digest but my intestine have problem and they don't reabsorb, then I start losing this fat in the stool, right? Typically the stool will be very sticky, it will stick to the commode, patient will have difficulty to flush it. So when patient gives that history, that means he has got steatorrhea. That means he has got steatorrhea. So Tapa, when you have loose stools or you have increased frequency of stools with the stool quantity more than 200 gram per day, when you are on a Western diet, we call it as diarrhea. But diarrhea along with blood in stool, we call it as dysentery. Diarrhea along with blood in stool, we call it as dysentery. Clear? Okay, so now Harrison gives a small table for us to understand the causes of chronic diarrhea. And I have highlighted the key causes that I want all of you to remember. The whole table of Harrison need not be memorized, so don't waste your time there, but the important ones I have highlighted. So when it comes to secretory causes, administration of exogenous stimulant laxatives. Laxatives are of different types, right? Stimulant laxatives, osmotic laxatives. So when you administer stimulant laxatives, that can cause secretory diarrhea. Then second, certain hormone producing tumors can cause secretory diarrhea. A classical example is lipoma or carcinoids. Can anybody tell me which hormone is produced by carcinoids? Carcinoids. Carcinoids produce a hormone called as serotonin. Okay. Serotonin stimulates the intestinal mucosa to secrete electrolytes and water. Okay. Similarly, lipoma is a tumor which produces vasoactive intestinal peptide, which also stimulates the intestinal mucosa to secrete more water. Right. So that is how we end up secreting more than necessary water into the stool, causing us to develop diarrhea. Okay. Now, osmotic causes, when it comes to osmotic causes, the first thing you should remember is osmotic laxatives. So magnesium salts or phosphate salts are usually used as osmotic laxatives. In fact, even antacids, right? You have this many antacids which contain aluminum and magnesium salts like magnesium silicate or magnesium hydroxide. They can cause diarrhea. Like you go to the pharmacy and ask for an antacid, half of the antacids will have a magnesium salt, and many of the times when you take that antacid, next day you will start noticing loose stools, right? So administration of osmotic laxatives, and then as I just discussed, deficiency of the enzyme called lactase, which is required for breaking down the lactose into its component monosaccharides, right? If I have the deficiency, it is produced by the breast border mucosa. If I have lactase deficiency or deficiency of any other disaccharidases, where I cannot break down the disaccharides, they are osmotically active substances, and if they are present in the intestinal lumen, I am not able to absorb them, I will end up losing water to that, right? Okay. Then similarly, presence of non-absorbable carbohydrates. Nowadays, this is becoming very common. In fact, a couple of weeks back, one of my gym enthusiast friend, he says that of late I am developing a lot of loose stools. From last 3-4 months, I am having loose stools. Okay. I asked him, tell me about your diet. So in his diet, he said that he is concerned about lactose intolerance. He is concerned. He does not have no proof. He is concerned. That is why he has eliminated the dairy from his diet. He does not take any dairy. Okay. But he was taking a soy-based, plant-based protein supplement. And this protein supplement had an artificial sweetener. The artificial sweetener was sorbitol. That was an artificial sweetener. You have many other artificial sweeteners like sucralose, right? These are all artificial sweeteners which are osmotically active. We do not absorb them, and that is why they are called as low calorie or no calorie alternatives, right? We do not absorb, that means they don't add calorie to us. They are sweet to taste, they go to intestine, we don't absorb, so they are not adding calories, that's why they are 0 or low calories, but they are osmotically active. So they won't go alone, they will take water along with that. That can cause diarrhea. especially when you take most of the thing you eat contains some or the other artificial sweetener, it can cause diarrhea. Okay, and then lactulose, like any of your sugars, you convert them into alcohol, they become non-absorbable, but they are osmotically active, they can cause diarrhea. Lactulose, we use it for therapeutic purpose, right? We use it as a laxative, and when we have patients with hepatic encephalopathy, to increase the gut mobility or to reduce the transit time, we give them lactulose, because when food stays for a longer period inside the intestine, the bacteria get more time to act on them and create more ammonia. That ammonia cannot be metabolized by liver, goes to brain, causes hepatic encephalopathy. So if you have to reduce ammonia levels in those patients, we have to increase the bowel movement so that the food does not stay longer period of time in the intestine. So we basically want to reduce the transit time. So for that reason, we use lactulose whenever we have patients with hepatic encephalopathy. Okay. Then when it comes to steatorrhea, where we have fat malabsorption, we are losing the fat in the stool. Yes, aspartame is also an amino acid derived artificial sweetener, a sweet amino acid made non-absorbable. But again, amino acids are also osmotically active. Even aspartame can cause diarrhea. Okay. Then steatorrhea, few more points to learn here, because many of the times when we go to some restaurants and eat some heavy meal with heavy fat, we might have some sticky stool. Can I call it as steatorrhea? No. So whenever you have more than 7 grams of fat per day of stool, right? Per day of stool. I am not talking about 7 grams of fat in our meals, right? When you take a standard diet and you have more than 7 gram of fat in your per day stool, like whatever number of frequency and quantity of stool you have, if the fat excreted in stool increases more than 7 grams per day, then we will call it as steatorrhea, right? In what all conditions it can happen? It can happen either because of impaired digestion of the fat maldigestion. And when maldigestion comes into picture, obviously the deficiency of enzymes is the most important thing. And which enzyme is required for fat digestion? Lipase, right? It can be produced by GIT, means the stomach, gastric lipase, and you have the pancreatic lipase, and majority of the fat digestion is done by the pancreatic lipase. So if I have pancreatic disorders, right, like chronic pancreatitis or fibrocalculous pancreatitis or pancreatic duct obstruction, in such cases the lipase deficiency will be there and I will end up developing impaired fat malabsorption, right? And that's why whenever you have chronic pancreatitis or pancreatic insufficiency, those patients receive lipase supplementation. Otherwise, they will not be able to absorb fat, and if they are not able to absorb fat, they will also not be able to absorb the fat soluble micronutrients, right? You have A, D, E key vitamins which need fat for absorption. Okay. Then if your digestive enzymes are fine, then the fat needs to be absorbed through the brush border of your intestinal mucosa. But if there is a problem with that intestinal mucosa, again you will not be able to absorb the fat. Even if you are digesting it, you will not be able to absorb. In what condition that happens? Most important is the celiac disease. Celiac disease is the most common intestinal mucosal disorder, which is very common. And I think as most of you know, it is because of gluten sensitive enteropathy. Those patients who are gluten sensitive, on exposure to gluten, there will be inflammation of the duodenal mucosa. Slowly duodenal mucosa will get atrophied and their ability to absorb nutrients will get affected. That includes fat, carbohydrates, proteins, as well as micronutrients like iron. And that is why many patients with celiac disease often present with iron deficiency anemia. Okay. Then you know Whipple's disease, which is caused by an infection due to Tropherema whippleri, right? Caused by an infection called as Tropherema whippleri. Okay. Then apart from that, there can also be impaired fat absorption if you have A-beta lipoproteinemia, intestinal ischemia, and certain drugs can impair with the absorption. Okay. So these are all causes for steatorrhea. Okay. Other than that, even if all goes well, I digest the fat, my mucosal layer absorbs it, then this absorbed fat has to be transferred or transported through the lacteals. If there is a pathology there like lymphatic obstruction, then I will not be able to transport the fat, right? Again, I will have leaking of this fat back into the intestinal lumen and I will end up developing steatorrhea. Okay. Now inflammatory causes, I mainly want you to remember the inflammatory bowel disease, or what you call as IBD. Under that you have Crohn's disease and ulcerative colitis. Apart from that, these two new types are added under IBD itself, called as lymphocytic colitis and collagenous colitis. So now IBD encompasses 4 entities. What are those? Crohn's, ulcerative colitis, lymphocytic colitis and collagenous colitis. These 4 things come under inflammatory bowel disease. Okay. Then chronic infections. Chronic infections caused by invasive bacteria, okay, certain parasites, they can also cause chronic. More on that we will discuss when we take up a special topic called as HIV and chronic diarrhea. Okay. Now there is one entity which was asked as an MCQ in one of the INI-CT, something called as Brainerd diarrhea, which Harrison mentioned, and that is why these INI people ask. Not very relevant for India, but I still want you to know. Brainerd diarrhea. Anybody has an idea what is Brainerd diarrhea? Brainerd diarrhea. So this refers to outbreaks of diarrhea that happened in some US districts. Like first outbreak was reported from a location or locality called as Brainerd, and that's why it is called as diarrhea. It is believed to be infectious, likely infectious, but the clarity on which organism may be responsible is not very clear. Many studies have shown like this organism may be responsible, that organism may be responsible, but there is no consensus to say that okay, this particular bacteria or parasite is responsible for someone developing the Brainerd diarrhea. But it typically occurs in outbreaks. And how do we know that this is caused by an infection? Because it has been observed that by consuming clean water and clean food during the outbreaks, patients are protected. But those who consume unclean water, they are at increased risk. So from there we understand that probably some infective organism is responsible, but exactly which organism, there is no consensus. We call it as of now as Brainerd. Okay. Now dysmotile causes is where intestinal motility can be increased, and intestinal motility can be increased in various conditions. One of the condition is inflammatory bowel disease. Inflammatory bowel disease, and then hyperthyroidism, right? Whenever you talk about hypothyroidism, we say constipation. In fact, it's one of the presenting complaints. Similarly, patients with hyperthyroidism, they present with diarrhea. Why? Because in hyperthyroidism, there is increased sympathetic nervous system activity, right? So that increases your intestinal motility and that can cause diarrhea. Clear? Okay. Then patients who have undergone cutting of the vagus nerve, right? We call it as vagotomy. Why vagotomy causes diarrhea? See, remember, sympathetic nervous system increases the intestinal motility, parasympathetic nervous system decreases. So whenever there is increased sympathetic activity that happens in hyperthyroidism, we can have diarrhea, right? Then if I cut the vagus nerve, I am cutting the parasympathetic control on the intestines, and thus the sympathetic activity would increase and I can develop the diarrhea. For what purpose we used to cut the vagus nerve? In the past, when we had non-healing peptic ulcers, we used to do vagotomy. Nowadays it is very rare because we know that majority of the peptic ulcers are caused by a bacteria, right? What is the bacteria? What is the most common bacteria responsible for the peptic ulcers, for which we have effective antibiotic treatment, right? Which organism I am talking about? Which is a repeatedly asked MCQ. Metronidazole and MBBS don't cause, they cause the colonic ulcers. Amoebiasis causes the colonic ulcers and drug of choice is metronidazole, but no, peptic ulcers, the ulcers in your stomach or in duodenum, yes, they are caused by H. pylori, right? Helicobacter pylori. And once we discovered that Helicobacter pylori is responsible for majority of the peptic ulcers, surgery is out of the box. Most patients, like I don't remember any patient whom I have referred for surgery because they have developed a peptic ulcer. But when I was in undergraduate days, right, my professors used to discuss about like the indications for referral to surgery, all that. That topic is now eliminated because it's not a big concern. So vagotomy is not routinely practiced nowadays. Okay. Apart from that, obviously for any complaint you talk about, there can also be a fictitious cause, means patient may be feigning or acting like they have a symptom, right? Okay, so these are the causes for chronic diarrhea. So we will just mention few important causes, right? So osmotic diarrhea, important one I want you to remember is lactase deficiency, which we call as lactose intolerance. Okay, and then use of osmotic laxatives, mainly containing the magnesium salts. Secretory diarrhea, most importantly I want you to remember the stimulant laxatives. Inflammatory chronic diarrhea, I want you to remember IBD and infections like Isospora belli, Cryptosporidium infections as the major causes. For dysmotility, I want you to remember the irritable bowel syndrome. Okay, and then for the steatorial, I want you to remember the pancreatic insufficiency, pancreas not being able to produce lipase, right? And then mucosal diseases like celiac disease or Whipple's disease. These are the important causes we have to remember. Otherwise, there is a table in the Harrison. Now, the next thing is, once I get a patient with chronic diarrhea, I already know that most of these causes are major causes, right? Here, I cannot be relaxed. Just like an acute diarrhea patient, I would say, take some ORS, take care of your hydration, and maybe in next 2 to 3 days, you will be all right. I can't take that attitude whenever I have a patient with chronic diarrhea, because all these diagnoses are major, right? Carcinoid, vipoma, use of osmotic laxatives or lactose intolerance, right? All these are major diagnoses, right? Inflammatory bowel disease, Crohn's, ulcerative colitis. So that means that I have to evaluate further. How will I evaluate further? Okay, now there is one flowchart given in the Harrison, but instead of taking this flowchart, we will take a slightly different approach, because in the end, we should be able to reach the diagnosis as well. We should be able to answer MCQs in the exam, right? So my first step when I encounter a patient with chronic diarrhea is to understand the source of diarrhea, whether this diarrhea is originating in the small intestine or whether it is originating in the colon. That will help me to rule in or rule out some of the differential diagnoses. For example, celiac disease. Celiac disease affects the duodenum. Whipple disease again affects the small intestine, right? On the other hand, the ulcerative colitis, as the name says colitis, affects the colon. Crohn's disease also predominantly affects the colon, though it can affect entire length from mouth to anus, it predominantly affects the colon. So if I am able to differentiate whether the origin of this diarrhea is in the small intestine or large intestine, half of my differential diagnosis will be out. From there, taking it to the diagnosis becomes easier. So what we will do is try to understand the difference between the diarrhea due to small intestinal pathology, we will call it as small bowel diarrhea, and diarrhea due to colonic pathology, we will call it as large bowel diarrhea. There are few parameters which will help us. The first one is, Rahul Yadav, we are unable to find the bug. So right now when I see the screen, both the channels are on. So we are not able to find where is the bug, why only one channel is getting conducted, neither in the streaming software nor on the YouTube platform. I am still searching. If you know any setting default which may be responsible for this, let me know. That will help me. Otherwise, the only option is to change the whole setup, but that will take some time. Okay. So now, what are we talking about? We are talking about how to differentiate between small bowel diarrhea and large bowel diarrhea. Okay. So first thing is, we will look at the stool volume. Okay. Now you should only tell me, logically thinking, if I have a pathology in the small bowel, my stool volume will be higher than the large bowel diarrhea or lower than the large bowel diarrhea? See, remember guys, I have already told you, we generally gift 9 liters of fluid per day to our small intestine. That includes the water we drink, the moisture and the fluid in our diet, and the secretions coming from the oral cavity, esophagus, stomach, and everything. So intestines receive around 9 liters of fluid. We absorb it efficiently and hand over only 1 liter of fluid to the colon, right? Colon will also absorb the fluids and electrolytes from it, and thus the stool we pass towards the end of the day is less than 200 grams, starting from 9 liters to less than 200 gram, right? From being very liquid in the intestine to relatively solid in consistency by the time it reaches the rectum to pass out as a stool. So now if I have a problem in the small intestine, what will happen to the stool volume? Yes, because in that case I will not be able to efficiently reabsorb. So stool volume will be high. So the stool volume in small intestinal diarrhea will be higher, and the stool volume in the large bowel diarrhea will be lower, because if I have a problem in my colon, right, let me say I have a problem in my rectum, I have proctitis. In that case, only small quantity would have reached there. Now if I am not able to handle it well, I will lose that small quantity, right. So the diarrhea, which is because of a large bowel pathology, will have small volume, and the diarrhea because of the small bowel pathology will have very high volume. Okay. Now what about stool frequency? The stool frequency is opposite of the volume. So large bowel diarrhea will have high frequency stools, and the small bowel diarrhea will have relatively low frequency stools. So the story of patients is very important. Like a patient who has a colonic pathology, his story will go like this. I go to bathroom repeatedly, but every time I go, इतना सा पास कर रहा हूँ, only small quantity stool I am passing, but हर आधे घंटे में, हर पौने घंटे में, हर 40 मिनट के बाद, every 40 minutes, 30 minutes, I need to go to bathroom. That's the story of a patient having a pathology in the large bowel. A patient having a pathology in the small bowel, he would say that I'm not going so frequently to the bathroom, maybe 3 times, 4 times a day I go, but every time I go, I'm purging large quantity of stool, right? And then comes the urgency. Generally, patients with a large bowel pathology will have urgency. Now what do I mean by urgency? जब आ रहा है ना तो रोक नहीं पाएंगे, दौड़ना पड़ेगा. They need to run to the loo. These small bowel diarrhea patients, they can control for some time. They don't have that urgency. मतलब they know that they have loose stools. Whenever they go to the bathroom, they will purge loose stools. But patients with large bowel diarrhea, they need to run to the bathroom. They have a urgency. So whenever we see urgency in part of the complaints, we know that we are talking about large bowel diarrhea. This distinction of small bowel versus large bowel can also be applied to acute diarrheas, but irrelevant there, because 80-90% cases we don't need to do anything. So that is why we don't spend time discussing all that. But for chronic diarrhea, I need to understand whether the pathology is in small or large bowel, and for that this urgency is also an important clue. Okay. Then there is a complaint called as tenesmus, right? Can anybody describe what is tenesmus? Tenesmus. Tenesmus. Tenesmus refers to struggle and pain while excreting the stool. Normally patients with small bowel diarrhea, you have loose stools, you go to the bathroom, you purge like anything. But these patients with large bowel diarrhea, small quantity आ रहा है, बार बार आता है, लेकिन हर बार जब जाते हैं ना तो एक struggle और एक दर्द feel होता है. They experience a bit of struggle and pain to pass the stool. That is what we call as tenesmus. Tenesmus is a feature of large bowel diarrhea. So whenever you have a colonic pathology or large bowel pathology, you can have tenesmus. Okay. On the other hand, tenesmus is unlikely to be encountered when you have a small bowel diarrhea. A classical example I can give you is when E. coli causes diarrhea, it predominantly affects your small intestine. Okay. I'm not going into chronic. To give you an example, because we will be able to relate to it, acute. E. coli, if it causes diarrhea, it causes small bowel diarrhea. Most of the E. coli patients will have frequent, they will have loose stools, large volume, but no major struggle to pass the stool. जैसे ही bathroom में बैठे हो गया. But amoebiasis predominantly affects the large bowel. So when you have amoebiasis, right, you will have frequent small quantity stools. You need to go regularly, frequently to the bathroom, and every time you go, there is a struggle and there is a pain. So that is a feature. Tenesmus is a feature of large bowel diarrhea, very frequently encountered in patients with amoebiasis, right? And then again, now you can relate. Where do I get mucus in the stool? Mucus in the stool is typical of the large bowel diarrhea. That's why a part of questionnaire that we ask whenever we have patients with diarrhea is, do you have blood and mucus in the stool? Why do we ask? Because if they say blood, that means they have dysentery, and when they have dysentery, it means it is caused by an entero-invasive organism like entero-invasive E. coli, Shigella, Campylobacter jejuni. These are all organisms known to invade the mucosa, not just infect superficially. right? And then we ask whether they have mucus in the stool. If they say they have mucus in the stool, it means mostly it is the large bowel which is affected. In India, the most common cause to cause large bowel involvement is the amoeba. We will not have mucus in the stool if I have a small bowel pathology, right? Similarly, blood in the stool, it can be present whether you have a small bowel pathology or large bowel pathology. But if, let me say, I start bleeding in the duodenum, right? By the time this blood reaches my rectum and passes out in the stool, will it look like frank fresh blood? No, right? Because this blood will get partially digested by the digestive enzymes produced by my intestine. So how this blood is going to look like? This blood will slightly be darker, right? What we call it as? We will call it as melena. So if there is an intestinal like enteroinvasive E. coli, it will invade the small intestine. So I will have a small bowel pathology. But because it is an invasive organism, I will start bleeding. When I bleed, this blood, as it passes along the intestine, it gets acted by bacteria, it gets acted by digestive enzymes, so it changes its consistency, changes its appearance. So by the time I pass the stool, it will become a bit chocolatey brown, dark. That is what we call as melena, right? On the other hand, I will have frank blood if the blood is originating in the colon. In that case, when we pass frank blood in stool, we call it as hematochezia, right? Melena refers to partially digested blood. One of the MCQ was asked on it, what gives rise to the coffee brown color to the melena blood? It is generally coffee brown in color. That is due to presence of what we call as acid hematin. Hematochezia refers to presence of frank blood in stool. That is why whenever we have ulcerative colitis, right? When we have ulcerative colitis, we will have frank blood in stool because the pathology is affecting the colon, which is large bowel. Melena refers to presence of blood in the stool but partially digested, not fresh blood. Why is it partially digested? Because whenever we bleed in the upper GI like esophagus, stomach or the duodenum, this blood as it passes along, it gets digested by the gastric acid as well as the digestive enzymes as well as the bacteria. That results in change in the color because we create what is called as acid hematin, that is dark in color. That's why we will have the coffee brown colored stool. We will call it as melena, and this stool is also again very sticky to the commode and difficult to flush. Okay, if I have frank blood, we will call it as hematochezia. So these are the points which will help me to differentiate whether a patient has got small bowel diarrhea or whether he has got the large bowel diarrhea. This table is a treasure trove for MCQs. Lot of MCQs have appeared on this differentiation between the small bowel and large bowel diarrhea. With this only, already half of my differential diagnosis will be clear. For example, if a patient presented with frequent small quantity stools with urgency, tenesmus and mucus in stool and blood in stool, and the duration is, let me say, 4 weeks, then it is a chronic large bowel diarrhea, right? It can be because of ulcerative colitis, it can be because of Crohn's disease, it can be because of an untreated MBBS or any other chronic bowel pathology. It can't be because of celiac disease, it can't be because of Whipple's disease, because they all affect the small intestine, right? So this is the approach that we need to take. Okay, Puneet, I will address that. Now what I will do is I will just spend 5 minutes to go through this Harrison's table. Okay, what he says that you have a patient with chronic diarrhea, rule out the iatrogenic drugs and surgery as the cause, which is anyway we will be already doing for all cases. We do take a past history and drug history. After that, he says if there is blood present in the stool, right, we should go for colonoscopy or biopsy. If there is fatty diarrhea present, that is steatorrhea, more than 7 grams of fat in stool per day. In such cases, he says we should go for small bowel imaging, biopsy and aspiration. Okay. And if from the history we get to know that there is pain also along with diarrhea, which is getting aggravated before meals, gets relieved by meals, or if there is a sense of incomplete evacuation, these are pointers towards irritable bowel syndrome. So in that case, you need to think of irritable bowel syndrome. And if there are no such features, no features of blood in stool, no malabsorption, in such cases we can consider functional diarrhea, and you can give a trial of excluding lactose from the diet or sorbitol from the diet to see whether the diarrhea stops. If it stops, that means the presence of the lactose or sorbitol was the reason, right? After this, if you have no clarity of what is the cause, he mentions a list of investigations which will generally help us to reach the diagnosis. I will just draw your attention to few. Okay, one of them is called as calprotectin. Calprotectin, right? What is it? It is a biomarker of intestinal inflammation. It's an inflammatory marker, just like how you have CRP as a marker of inflammation of the whole body. Calprotectin is a marker of inflammation of intestines. So if it is elevated, means you have an inflammatory diarrhea. Most common cause being IBD, ulcerative colitis, or Crohn's disease, right? Then he mentions one more investigation here, which is TTG-IgA. TTG-IgA refers to tissue transglutaminase IgA type of antibody, right? This is the antibody that is seen in patients with celiac disease. In celiac disease, body produces antibodies against the tissue transglutaminase, and because of that we end up damaging the mucosa, mainly the duodenum. So there are certain clues which these investigations can give. According to that, we do a further evaluation. For most of us, we don't need to really bother further, because all the entities that we discussed today, like vipoma, right, carcinoids, then lactose intolerance, Crohn's disease, ulcerative colitis, all of this we will be discussing subsequently, celiac disease, Whipple's disease. So as we discuss more, we will develop an approach to all these disorders. Just to give you a summary, whenever now you go to the bedside and you hear the patient complaint as diarrhea, first thing is to see whether it is acute or chronic. If it is acute, we have already discussed the approach. If it is chronic, at least be able to differentiate whether it is the small bowel diarrhea or large bowel diarrhea. Once you have that clarity, you know that you can make a small list of differential diagnoses. If your end diagnosis is this is a large bowel diarrhea, then you can make a list of what are the diseases which affect the large bowel. If it is a small bowel diarrhea, what are the diseases that affect the small bowel, right? So calprotectin is a substance released in response to inflammation of the intestines. Your large and small intestine, when they are inflamed, it produces calprotectin. Similarly, these are all inflammatory proteins. So if there is an intestinal inflammation, this can be secreted in stool, as well as the blood levels of calprotectin can increase. We generally check the stool calprotectin levels. If it is increased, that means intestines are inflamed. And in what conditions intestines can be inflamed? Inflammatory bowel diseases, right? Ulcerative colitis, Crohn's disease. Shobhi Khan, okay, I will address that. Puneet, what is your query? Puneet, see, when it comes to healthcare, right, every part of healthcare is essential and crucial. So sitting here as a physician, I can't say that सिर्फ मेरे से patient का care का काम चलेगा, नहीं, right? I am mostly a diagnostician. So when patient present to me with कुछ complaints, I will be able to diagnose it, okay, and maybe I can prescribe the medications. But अगर treatment में surgery की ज़रूरत है, तो I am not the right person. I have to refer it to a surgeon. Only surgeons can operate. वैसे ही even after surgeons operate, there is need for physical assistance for patient to get back to his normal position that he was earlier before the development of disease. So उसके लिए rehabilitation therapy, physiotherapy, वो सब ज़रूरी होता है, right? Similarly, nursing is also an important part. मैं तो सिर्फ दवाइयाँ लिख के चला जाऊँगा, right? Who will give it to the patient on time without mistake? Who will administer the injections? Who will bring the human touch to care? It is the nurse. So कोई प्रोफेशन बड़ा छोटा नहीं होता है, एंड कोई प्रोफेशन बहुत ज़्यादा स्कोप वाला या बहुत कम स्कोप वाला नहीं रहता है. Everything has a place, and every place, right, depending on your capabilities, you can reach this peak. There are physiotherapists who have become physios for cricket teams. They earn more than me, more than any doctor, right? A physio to Indian cricket team or a IPL franchisee will definitely earn more than any doctor per se, right? Similarly, like people in nursing care, if you are taking care of some big person, obviously your pay will be bigger than a celebrated doctor. So in terms of revenue, yeah, in terms of scope, nothing is smaller, nothing is larger. All we have to decide is whether I have the capability and credibility to take this up, whether I have the capability to hone the role of a doctor, a nurse, or a physiotherapist, and whether I will be happy with this kind of work. Right? So I unfortunately I will not be able to say nursing is superior to physio or physio is superior to nursing. ऐसा कुछ भी नहीं है. Okay. Nilanjan Roy, CRP will get elevated whenever there is inflammation in the body, in any part of the body. It is not specific to some system. While calprotectin is specific to intestines, it will get elevated when intestinal inflammation happens. But CRP, I have arthritis, it will get elevated. I have COVID, it will get elevated. I have dengue, it will get elevated. I have fractured my bone, it will get elevated. So CRP, inflammation anywhere, it gets elevated. It is not specific to an organ or tissue, while calprotectin is specific to your intestines. So guys, remember, Shobhikan, see, syndrome refers to collection of clinical manifestations. Okay, like when 2 or 3 different clinical manifestations come together, we call it as syndrome. Okay, now the syndrome will have an underlying cause. The cause can be an infection or a genetic abnormality. See, when you say pathology, what does it mean? Altered physiology. Normally body के लिए एक defined parameters हैं, defined functions है, राइट, एनाटमी, फिजियोलॉजी, कुछ डिफाइन नॉर्मल सी है. नॉर्मल से कुछ भी हट गया तो वो पैथोलॉजी है, राइट. मतलब हार्ट रेट है 60 to 100, दैट इज़ नॉर्मल रेंज. अगर उससे कम हुआ तो वो पैथोलॉजी है, उससे ज़्यादा हुआ तो भी पैथोलॉजी है, वो नॉर्मल नहीं है. सो व्हेन यू से पैथोलॉजी, इट मीन्स यू आर सेइंग नॉर्मल से कंडीशन हट चुका है, इट हैज़ बिकम डिफरेंट फ्रॉम नॉर्मल सी. अब क्यों हट गया है, उसका कारण क्या है? उसका कारण इन्फेक्शन हो सकता है, जेनेटिक प्रॉब्लम हो सकता है, राइट, डॉक्टर्स के दिए हुए मेडिसिन या ड्रग्स हो सकते हैं. सो देन अंडरलाइंग कॉज टू पैथोलॉजी, वन ऑफ देम कैन बी इन्फेक्शन, राइट. जस्ट टू गिव यू एन एग्जांपल, राइट, डेंगू. डेंगू में होता क्या है? डेंगू में फिजियोलॉजी से हट के क्या होता है? व्हाट इज द चेंजिंग इन डेंगू? प्लेटलेट काउंट्स गिर रहे हैं. नॉर्मल प्लेटलेट काउंट कितना है? 1.5 lakhs to 4.5 lakhs पर क्यूबिक मिलीमीटर. उससे गिर गए तो वी हैव डिविएटेड फ्रॉम नॉर्मल सी, नॉर्मल से हट गए, इसलिए पैथोलॉजी है. पैथोलॉजी को हम क्या कहेंगे? वहाँ पे है थ्रोम्बोसाइटोपिनिया. क्यों हो रहा है? बिकॉज ऑफ द इन्फेक्शन बाय डेंगू वायरस. सो इन्फेक्शन इज वन ऑफ द रीजन फॉर डेवलपमेंट ऑफ पैथोलॉजी. पैथोलॉजी हैज रिजल्टेड इन क्लिनिकल मैनिफेस्टेशंस. ऐसे ही अलग अलग क्लिनिकल मैनिफेस्टेशन साथ में आ जाते हैं तो वी विल कॉल इट एज सिंड्रोम. ओके, सो गाइज, फॉर टुडे this is it. This is what we are going to discuss. We have understood what is diarrhea, how to define it objectively, subjectively, how to differentiate it between acute, subacute and chronic, how to approach an acute diarrhea, and a brief description of how to approach a chronic diarrhea, mainly concentrating on differentiation between small intestine and large intestine diarrheas. In the subsequent lessons, we will understand individual entities. As we go forward, we will discuss all the names that we have taken today. For now, I am signing off. I will share some MCQs for you to address. Some of them you might find it difficult for now because they talk about little forward thoughts which we are not discussed, but it will initiate you into thinking, and hopefully as you come back, you will be able to answer more such questions. I'm signing off for now. I wish you all the best for your studies and have a good night. I'll see you in the next session, which is probably scheduled on 27th, I guess, and I will let you know the topic through the social media. Bye guys, have a good night. Good night.